Good afternoon, everyone. Once again, Newton-Wellesley Medical Group Lunch and Learn here on a Thursday afternoon. We are really excited to have Dr. Larry Friedman to come join us, talk to us how I approach abnormal liver function tests. We are always excited to have our chair of medicine here give us a talk about how we can manage our liver function studies in our offices. And we are excited to have this talk, and I'm going to talk fast because I want to give him the stage as much as possible. But a couple announcements, as always, as we go. Next slide, Larry, if you could. We have upcoming lunch and learns. We just want to remind folks on April 21st, it'll be school vacation week. Good chance to catch up on our old talks. You can find them on our intranet as well as on YouTube by searching Newton-Wellesley Medical Group Lunch and Learn. Next. We also want to remind folks once a month, we have a great opportunity for another learning opportunity here at Newton-Wellesley, our APP Grand Rounds. This Grand Rounds will be supported by the Department of Anesthesiology. It's on, I think it's on perioperative pain management, although I don't see that on the slide, but I do believe that's what it's on. Next slide. Oh, yes, we want to tell people about this. This is new for all our physicians and APPs out there. We are trying to get together a softball team. Softball games will happen on Tuesdays and Thursday evenings. You are not signing up for every Tuesday and Thursday evening, I promise. Any one that you can give us. They're about 2 hours in length or so. Lots of fun. You do not have to be good at softball. Please, if you're interested in this, please contact Dan Destin at his email there, or you can contact me and come watch us or come play with us. It's going to be a lot of fun. Next slide. We have our financial wellness series is continuing. Our next one is coming up next Wednesday on long-term care planning, a topic that a lot of doctors have asked me to get a speaker on. So we are happy to have that on. Again, this is a no pressure situation. We did choose 6:30 to 7:30 p.m. so you can get home and watch this with a significant other if you'd like. They are also will be recorded and are posted if this is not a great time for you. But again, this one we have handpicked these topics, and this one's going to be on long-term care planning. So please join us either live or on recording. Next slide. And then the Pay It Forward program still continues. This is a acknowledgement to any physician who has helped you along with a difficult case. You give them a Pay It Forward, they get a $100 gift certificate, and then from there, they would pay it forward to another physician or APP, and so on and so forth. Next. And I will stop talking. Dr. Friedman, thanks so much. Just one reminder that you are still on mute, and I.
How's that?
Perfect.
Can you hear me? Okay.
Yes, we can. Go ahead, Larry.
Well, thank you. I intend to talk 3 times as fast as Dr. Snyder. We have a lot to cover. Word about my royalties. I write about 45 or edit 45 chapters for Up to Date, including the 6 on liver biochemical testing, and the one entitled Approach to the Patient with Abnormal Liver Tests is the #1 accessed topic in the GI section, and of the 10,000 or so topics, it's #4 overall. So there's obviously an interest in this. These are my objectives, basically to tell you how I think about this. I don't like the term liver function test because the main tests, Amino Transferase and Alkaline Phosphatase, are really not tests of liver function. The actual tests of liver function are the bilirubin, albumin, and prothrombin time. As you can see in the child Turcotte-Pugh score, which is a prognosticator for cirrhosis, that includes all 3 of those elements. And even in the model for end-stage liver disease score, the bilirubin and INR are included. In 2016, the serum sodium, by the way, was added. Caveat about the prothrombin time, it's useful for assessing the severity of liver disease, and as a prognostic factor, it does not correlate well with bleeding risk. And we always have a problem with that because people are always demanding that we give fresh frozen plasma to people with prolonged prothrombin times prior to procedures. And that tends to do more harm than good because of fluid overload. Part of it is the way the INR is calculated based on therapeutically anticoagulated control blood, not liver disease control blood. So when you look at the patterns of liver chemistry abnormalities, we talk about hepatocellular disease, cholestatic disease or mixed, sort of cholestatic hepatitis. And there are actually guidelines for that called the R value, the ALT to AP ratio based on times normal. And if it's greater than 5, it's hepatocellular. If it's less than 2, it's cholestatic, and in between is mixed. And the temporal patterns of liver disease have been defined. Believe it or not, acute liver injury is injury that occurs up to 6 weeks from the initial insult. So this is drawn out over a period of time. Now, when should you be checking people for liver biochemical tests? We used to do it routinely, and we used to do it preoperatively, invariably. That doesn't seem to be cost effective. So there are indications for liver biochemical testing as shown here. So the rest of the talk is some examples of common clinical problems. The first is persistent elevation of the aminotransferase levels. Some people call this transaminitis. That's a word that should not be used in my presence. The aminotransferases, not the transaminases, are not inflamed. They're elevated. And you always want to make sure that the elevation persists before you evaluate a patient with this pattern of abnormality. Now, as you've been taught, ALT comes predominantly from the liver, but it can come from muscle. AST comes from a variety of organs. The normal values are actually lower than the laboratory report. Some labs give the ALT up to 50 or 60, but those normals were derived from studies in the 50s and 60s before we knew about fatty liver and hepatitis C. So the normal values are actually lower than previously thought. I would give an upper normal for a man of 35 and a woman of 25 before I consider evaluating it. There are correlations with the aminotransferase as shown, including in some studies mortality. So there are things that can affect the ALT level, including what I call a Big Mac attack. In one study, someone ate a Big Mac every day for 30 days and watched his aminotransferase levels rise. But over time, they came down again because of adaptation. The same will occur if you take 4 grams of acetaminophen a day. That's not toxicity, it's an effect. Statins cause some mild elevations of the aminotransferase levels. Interestingly, they decline with age and they're dialyzed, and caffeinated coffee reduces the aminotransferases and actually protects against many kinds of liver disease. So let's talk about statins. They typically will cause a mild elevation of the aminotransferases, occasionally more than 3-fold. This is because we're changing the composition of membranes, including hepatocyte membranes. It's really a nonspecific effect. True hepatotoxicity from statins is rare, and we don't think there's a need to monitor liver enzymes when a person's on a statin. And liver disease is not a contraindication unless the liver disease is advanced and there's really no need for statin use. Statins probably decrease the risk of certain types of cancer as well. You've heard a lot about the AST to ALT ratio. Marshall Kaplan at Tufts, an esteemed hepatologist, chief of the division of gastroenterology for 41 years, wrote a lot about this. He discovered that in alcohol-associated liver disease, the ratio is often at least 2 to 1. In non-alcoholic fatty liver disease, chronic hepatitis, the ratio is less than 1, but as cirrhosis develops, the AST rises above the ALT because it's cleared more slowly. In acute muscle injury, AST predominates, but interestingly, over time, the values equalize. So here's the differential diagnosis of mild aminotransferase elevations. Drugs and alcohol lead the list, non-alcoholic fatty liver disease, and viral hepatitis, usually chronic hepatitis for these mild elevations. But there are other causes as shown in this slide. So after you've worked up the patient, if you don't have an explanation, although that's less common now than when some of these studies were done, but if you don't know the answer, should you do a liver biopsy, and under what circumstances? For any elevation, for 2 standard deviations above the mean. We don't really know. Whatever your cutoff is, you're going to find fatty liver disease most of the time, at least 2/3, but you'll also occasionally find an unexpected finding. This is a study from 20 years ago showing non-alcoholic steatohepatitis and fatty liver were found in 2/3 of patients who had undergone an appropriate serologic workup as shown above, but then other diagnoses, including normal liver, can be found, as well as an occasional case of cirrhosis. So non-alcoholic fatty liver disease is the predominant liver disease of our time now that we can cure hepatitis C and suppress hepatitis B. It is the hepatic manifestation of the metabolic syndrome. It affects kids now and adolescents as well as adults. And the name, a name change has been proposed to metabolic associated fatty liver disease. And that's being debated in the liver world because it does have implications. But this is what you'll find most of the time in these cases. And you'll find it a lot in the United States because we are an obese country. The overall rate of fatty liver is up to 1/3 of the population, and it goes up if diabetes, obesity, and more severe obesity is present, as shown here. There's a spectrum of disease that mimics alcohol-associated liver disease, from isolated fatty liver in 80%, non-alcoholic steatohepatitis in 20%, and it's NASH in particular that can cause fibrosis and eventually cirrhosis. And so cirrhosis is a major risk factor for hepatocellular carcinoma. Rarely, NASH can lead to hepatocellular carcinoma in the absence of cirrhosis, but it's infrequent enough that we don't screen those patients for hepatocellular carcinoma if they don't have cirrhosis. So when should you suspect non-alcoholic fatty liver disease? When the aminotransferases are persistently elevated, but in 40% of cases, they're normal in NAFLD. And in that case, you may pick it up on an ultrasound. The problem with ultrasound is, while it's sensitive for higher degrees of steatosis, it's not sensitive for fibrosis. And so, at least in the past, liver biopsy would be required to see if this patient has advanced fibrosis and it could be at risk of hepatocellular carcinoma. Now, a former student of mine developed the Fibrosis Iv Score, in which age, AST, ALT, and platelet count are used in a formula to predict the presence of advanced fibrosis. A low score is quite reliable for excluding advanced fibrosis. High score, suggestive of advanced fibrosis, but not quite as reliable. And this test has been recommended. In fact, some have suggested that if you get a CBC and liver test, it should be automatically calculated on the lab results because it's a good screening test to exclude advanced fibrosis. This is the test that I generally use first. There are others, the NAFLD fibrosis score, it's a little more complicated. And then there's imaging in the form of transient elastography. This is a point of care ultrasound test that measures liver stiffness. And I'll have more to say about that a little later. Regardless of what you find, the treatment of fatty liver is usually weight loss and exercise. And you can see the degree of weight loss correlates with the reversal of findings on liver biopsy, including the reversal of fibrosis. The problem is it's easier said than done. And with regard to weight loss, only about 10% of people achieve a weight loss of 10% after a year, and only 10% of those maintain it. So drug therapy is of great interest. There are some drugs that have been studied as shown and may be used in practice. They all have limitations. Many others are under study. None is FDA approved. When should you refer a patient to a hepatologist? I think you can carry the workup to the point of excluding fibrosis. And if you have excluded fibrosis by the Fib4 test or ultrasound elastography, which you can order here through radiology, I think then you can manage that patient. You can tell them to lose weight as well as I can. But if they have advanced fibrosis, then they need further evaluation for complications of cirrhosis. That's when you should refer those patients. Now, other causes of persistently elevated aminotransferase levels. Turns out celiac disease is a common cause, more common than alpha-1 antitrypsin deficiency and Wilson disease, which you all test for. But in patients with elevated aminotransferase levels, 3 to 4% will end up having celiac disease. The histologic correlates are quite variable, but this can be the only manifestation, and it resolves on a gluten-free diet. Some of these patients go on to develop advanced liver disease. Mild elevations of the aminotransferases can be associated with hemochromatosis, and there, if the transferrin saturation or serum ferritin are elevated, then you should do genetic testing. The transferrin saturation no longer has to be fasting. So here's the next case. This is a case of hepatitis. Notice that this patient has jaundice. You can get jaundice with cholestatic or with hepatocellular injury. The elevation of the bilirubin does not help determine the cause, just the severity. The other thing to keep in mind is everyone deserves a history and physical, so you always interpret these results in context. So this is the differential of acute hepatitis. The hepatitis viruses, some other viruses, usually not with terribly elevated aminotransferase levels, always include drugs and toxins in your differential, and here you include some other entities as shown. Sometimes other diseases can mimic hepatitis, like acute biliary obstruction. So I've talked about at a previous lunch and learned the serologic diagnosis of viral hepatitis. The key tests are shown. For hepatitis B, the presence of IgM anticore with surface antigen indicates acute hepatitis. For hepatitis C, you should always get the HCV RNA because the antibody appears late in the course. Notice you don't have to get the E antigen or HBV DNA to diagnose acute hepatitis B. You do have to get them when you've established a patient as chronic hepatitis B, because then you have to stage the phase of the disease. And it's only the people with high HBV DNAs and elevated aminotransferase levels in the immune clearance phase or the reactivation phase that we actually prescribe antiviral treatment. Alcohol-associated hepatitis is associated with fairly modest aminotransferase elevations, including, in fact, the ALT can be normal or near normal. That's in part due to pyridoxine deficiency, which is a cofactor in the enzyme. So the differential diagnosis of drug-induced hepatitis or any type of liver disease is extensive. And you can't remember all of these. Oh, you remember that acetaminophen is the archetypal cause of dose-dependent hepatotoxicity. And then there are idiosyncratic reactions, either an immunoallergic that can even lead to DRESS syndrome or metabolic idiosyncrasy. But you don't have to remember it. You have to review the drugs and look them up in livertox.nih.gov. It catalogs 1,200 substances that may or may not cause hepatotoxicity and the pattern associated with it. This is an invaluable reference. And it does the same for toxins, herbal and dietary supplements, and drugs of abuse, as shown here. And I will tell you, those herbal and dietary supplements are taken by people. They do cause a lot of the hepatotoxicity that we see in practice. Now, Wilson's disease has a wide spectrum of presentation, anywhere from asymptomatic elevations of the liver test to acute liver failure. So you have to think about it, particularly in a person under 40. And in acute liver injury, it's been shown that the aminotransferases almost never go above 1,500. And there's an interesting pattern where the AST to ALT ratio is over 2.2 And the alk-phosphobilirubin ratio is less than 4 because these patients have a low alkaline phosphatase because copper displaces zinc as a cofactor, and a high bilirubin because of hemolysis. There are mimics of acute hepatitis. An acute rise occurs with acute biliary obstruction. That's usually associated with severe pain. The alkaline phosphatase rises more slowly because it's synthesized, not released. And replacement of the liver with tumor can cause an acute hepatitis pattern. Finally, COVID can be associated with hepatitis, either because of an immune response to the virus, direct toxicity, drug-induced liver injury, or other mechanisms as shown here. So here's an example of severe hepatitis. The aminotransferases are sky high. We call them towering. Notice in this case, I would get an LDH, and I'll show you why. The differential is limited. Toxic hepatitis from certain toxins like acetaminophen and ischemic hepatitis, those are the two main causes. Sometimes we see this in viral hepatitis. I've seen it in E and B in particular. Now, acetaminophen toxicity occurs in one of two flavors, either a frank overdose or the so-called therapeutic misadventure, where an alcoholic or someone who's been fasting for a while takes relatively high normal doses, like 3 or 4 grams a day for a period of time. And because they're missing glutathione, or in the case of alcohol, they have an increase in cytochrome P452E1 activity, they produce a toxic intermediate. Ischemic hepatitis has this pattern. It usually occurs in the setting of heart failure, but it can occur in respiratory failure as well. There's a sky-high rise in the aminotransferases, as well as the LDH. And the ALT to LDH ratio is less than 1.5 in contrast to viral hepatitis. And they come down very quickly if the patient lives. They don't tend to die of liver disease, they die of their underlying cardiac disease. Here's an example of hepatitis, but you can tell it's chronic because the albumin is decreased. The albumin's half-life is 18 days, so it takes a while. This has been going on for a while. We also note the high globulins. And this is the differential. The high globulins do make you think of autoimmune hepatitis, but other chronic liver diseases can do that as well. And there are criteria for the diagnosis of autoimmune hepatitis. It's a clinico-pathologic diagnosis, so it requires a liver biopsy. The autoantibodies are sometimes not present. The immunoglobulins are sometimes not elevated. Hepatitis caused by a virus should be absent. Now, you need to stage chronic hepatitis, and that means how much fibrosis there is, from just portal fibrosis all the way to cirrhosis. Liver biopsy was the gold standard, but it's not that gold. It's tarnished. If you biopsy here, you get a much higher fibrosis area than if you biopsy here, and it may not look like cirrhosis. So you get sampling error. So we've looked for indirect and direct markers of liver fibrosis, such as the Fib score that I told you about. For viral hepatitis, we use the Brochure test. This is a test that you just order. You don't have to order the individual parameters. And just like the Fib4, if the score is low, unlikely to be advanced fibrosis. If it's high, probably advanced fibrosis, large indeterminate group. And increasingly, we rely on elastography. You can do the point of care fibroscan or order it by ultrasound as we do here. We don't have fibroscans, and they can do ultrasound elastography, either 2D shear wave or acoustic radiation force. The best test, but most expensive, and the one we reserve for equivocal cases, is magnetic resonance elastography. And right now we have to order that at MGH. And you can see in the right panel where a lot of the liver is yellow and red, that's a very high stiffness score indicating a high fibrosis degree. It's measured in, stiffness is measured in kilopascals. And this can obviate the need for liver biopsy in over half of cases. So a few more quick cases. Isolated alkaline phosphatase level, again, do your history. If the patient's pregnant, that's an answer. But assuming the history is not revealing, you prove that it's a hepatic source with either an elevated GGTP, which is relatively nonspecific for the liver, or 5' nucleotidase, which is a bit more specific. And this is the differential. Always start with drugs: primary biliary cholangitis, other granulomatous diseases, infiltrative diseases, and a variety of biliary diseases. The drugs that cause pure cholestasis are shown here, but remember to check with liver tox. The common causes of cholestatic hepatitis are shown here, and amoxicillin clavulanic acid is probably the most common cause of drug-induced liver injury. Primary biliary cholangitis, formerly cirrhosis, is well known to you. In addition to the disproportionate alkaline phosphatase elevation, cholesterol and IgM are elevated. The aminotransferases are modestly elevated. There are these prognostic models, and notice we use the Mayo risk score, which includes bilirubin, albumin, prothrombin time, the liver function test, to assess prognosis. And you actually don't even need to do a liver biopsy in these patients. And response to therapy is generally monitored by a reduction in the alkaline phosphatase. This is a case of cholestatic liver injury with jaundice. And here, the focal point for evaluation is the ultrasound. If the ducts are dilated, you have to evaluate them, starting with magnetic resonance cholangiopancreatography. If they're normal, the first disease you think of is primary biliary cholangitis, and you do an AMA. And if you're wrong, you just go to the other part of the algorithm. MRCP is very good for diagnosing sclerosing cholangitis. In that case, you have to get an IgG4 level, because IgG4-related liver injury, liver disease can mimic PSC, and in PSC, a high IgG4 level has an adverse prognostic sign. Lots of ways cancer can cause jaundice is shown here, but for metastases or primary tumor to cause jaundice, it has to fill the liver. You don't get jaundice until that's late. Finally, there are systemic causes of cholestasis as shown here. I won't belabor the point. I do want to mention the ICU cases where sepsis, heart failure, and parenteral nutrition are common. There's also this entity of sclerosing cholangitis in patients in shock, and this can mimic sclerosing cholangitis, but it rapidly advances to cirrhosis. Final case of jaundice, isolated bilirubin elevation. This is indirect, and you'll all recognize that this is Gilbert syndrome, but you have to make sure that this is not hemolysis. If it's direct hyperbilirubinemia, we think of a bile transport defect. Sometimes jaundice can be profound. The highest level of bilirubin in the literature is 280. The highest I've seen is 177. And usually it's always multifactorial, such as a sickle cell patient with either hepatitis or biliary obstruction. And if you throw renal failure on top of that, the bilirubin gets very high. So here's your final exam. I'm going to give you 3 quick cases. Isolated alkaline phosphatase elevation or disproportionate for the most part. This is classic amyloidosis. AST, more than twice the ALT, alkaline phosphatase relatively low, high bilirubin. This is acute Wilson disease. And finally, high total bilirubin, non-specific enzymes. And this is classic for right-sided heart failure. This would be tricuspid regurgitation. I write the chapters on liver and heart failure for UpToDate also, if you want to read those. So key points. The pattern of elevated liver biochemical test levels may be categorized as hepatocellular, cholestatic, or mixed based on the R value. Standard tests of liver function are the serum bilirubin, albumin, prothrombin time. Non-specific, but still helpful. Jaundice may be either hepatocellular or cholestatic. Regardless of the pattern, a drug etiology is always in the differential. Use livertox.nih.gov. Most cases of persistently and mildly elevated aminotransferase elevations are due to NAFLD. That's what you'll see most in your practice. And with that, I thank you very much for your attention. As time permits, I'll be happy to answer questions.
And thanks, Larry. So we are at the top of the hour exactly. Well, that was really well planned. But if you have any questions, throw it in the chat box. I'm going to take advantage real quick because the question that often comes up in my practice is the reverse, which is we're doing a scan for another reason, and the radiologist gives us hepatosteatosis or fatty liver infiltration only as a somewhat finding, even though the LFTs are normal. What do we do with that besides kind of shrug our shoulders and tell the folks to kind of lose some weight? You have fat in your liver.
That's exactly what you do. So it turns out if the aminotransferases are normal, but fatty liver is seen on ultrasound, the prognosis is good. Those people usually don't get into trouble. Assuming they have risk factors, and remember, 15% of people with non-alcoholic fatty liver disease don't have risk factors. Assuming they have risk factors, treat the risk factors. You can obtain a fibrosis test. I would only refer those patients if one of the fibrosis tests is high. You can do a series of fibrosis tests. You can do the FIB4 followed by ultrasound elastography. If they're high, then you can refer them. But that's what I would do with those patients.
Excellent. Then there's another question which we also vex with a little bit, which is, when you get the elastography, does it need to be repeated? And if so, what would be the interval that would be ideal?
Yeah, I think a lot of my colleagues overuse these. I check a liver fibrosis test every several years. Some people, when they have point of care elastography, check it at every visit. Fibrosis does not evolve that quickly. And by the way, elastography is not terribly helpful for documenting reversal of fibrosis. So I do it every several years, 3 or 4 years, because it's glacial in terms of changing.
And from a primary care point of view, someone with NAFLD, do you go ahead and do the things we would typically do with some of the chronic hepatitis, which would be immunize them against other hepatitises, tell them they can't drink anything or really should cut it back, avoid Tylenol, or how do you manage that?
So yes, yes, and no. Everyone with liver injury should be vaccinated against A and B. Anyone who has the word liver in a diagnosis should be advised to reduce alcohol intake. Harm reduction. So you may not be able to be absolute about that, but less is more. Remember, for a woman, 2 drinks a day for 10 years can be associated with cirrhosis. For a man, it's 4 drinks a day. So it's not that much. People need to cut back. Acetaminophen is perfectly safe in liver disease. And I just suggest, to be safe, don't take more than 2 grams a day. The problem with acetaminophen is if you are have alcohol use disorder, and because that's the real thing that revs up its metabolism to the toxic intermediate. But liver disease is not a contraindication to treatment with acetaminophen in modest doses.
Wow, thanks, Larry. This has been a great review. We want to remind folks we're back here next week. 2 other things real quick. Of course, Dr. Friedman hosts an amazing medical grand rounds every Wednesday morning at 8:30. Which does come flat on with CME credit. Take it from your comfort of your home or your office. Please take advantage of that learning opportunity. And we have an APP grand rounds coming up again. And we hope to see everyone. Hope everyone has a nice weekend. Shout out to my wife who has a birthday today. Happy birthday, Jen. Hope you're still on the call. And otherwise, we'll see everyone next week. Thanks, Larry. Bye.